morning. Our case today is a 70-year-old male. He's a smoker, hypertensive, and dyslipidemic. Presented with effort angina class 3 accelerating to class 4 within the past month, with an ST depression and T-wave inversion in the anterior leads, ejection fraction 45% with segmental roll motion in the LED territory. This was his coronary angiogram. As you can see, we have a heavily calcific subtotal circumflex, and here in the LED, you can appreciate the almost total occlusion with heavy calcification. As you can see in two orthogonal views, so it must be at least an arc of 270 calcification. The RCA was a small vessel, probably a co-dominant vessel, but small in caliber. So our strategy here was to do a syntax score for the patient. His syntax score was 35, with a syntax score 2 of 41 for PCI and 42 for CABG. So the decision was either CABG or PCI. He went to the surgeons and they said they won't graft the right coronary, so we can go for both, either CABG or PCI. The patient refused CABG, so he was referred for PCI in another center. They tried to pass a balloon in the LED. Of course, it was a balloon uncrossable lesion, even after using body wire with a 7 French XB, and nothing passed, even a 1.0 balloon. So our strategy here for balloon uncrossable lesions, he used everything in the algorithm except we can go for rotational atherectomy. So he was referred to our center for rotational atherectomy. We went with a 7 French XB. We decided to do PCI to the LCX first, then to the LED to support the circulation. We tried a balloon, a 3.0 non-compliant balloon. As you can see, it's not inflating well. So this is a balloon undilatable lesion. So we went with the IVUS, and it revealed a horseshoe calcification in the circumflex. So we decided to go with rotablation to the circ. After multiple runs of rotablation, we did balloon NC 3.0. As you can see here, it inflates very well. You must make sure that you inflate the balloon well before putting the stent. This was after inflation. Actually, the dissection makes it better for us. And then we put a 3 by 48 stent. Then post-dilatation after an IVUS run with a 3.5 NC balloon in the proximal part. And this was the final circ result. Then, actually, when we passed a 1.5 rota burr, it couldn't pass, and as you see, the rota wire migrated proximally. So we entered again and put it distally, and it couldn't pass the 1.5. So we took a 1.25 rota burr. It passed after 3 times of manipulations. This was the 1.25. And then the 1.5 burr actually passed after the 3rd time. It was a very heavy calcification in that part. This was the final polishing run. And then we took a 3.0 balloon. We decided, as you can see here in the LED, this was a sizable diagonal with almost a subtotal occlusion. So we decided to do a mini crush for the diagonal in LED by stenting the diagonal first, and then crushing with a 1-to-1 non-compliant balloon. It was a 3.0 balloon. And then we put a stent, 3.0 by 38, in the LED. And then a proximal stent This is the modification of the crush technique with a crush pot and then a pot, and then recrossing and kissing, and then a final pot with a 3.5 NC balloon. And this was the final result of the LED diagonal in the spider view and in the cranial view. So my take-home message is that you must know your tools and equipment and don't start except if you have them all. In this patient, he had a heavy calcification and the operator tried to open it despite all this calcification without having rotablation or cutting balloon or scoring balloon in his center, which I think is very wrong. Intracoronary imaging by IVUS or OCT is essential in the calcific vessels to know the type, extent, and thickness of calcium, which will affect the decision making. Rotablation is an essential tool in heavily calcific vessels and is almost the only option in balloon uncrossable lesions. We don't have a laser in Egypt, so that's the, or we don't have laser or even the, okay, so rotablation is essential in the heavily calcific vessels. Interventional cardiologists must have experience with IVUS and rotablation to increase success of the procedure and for better long-term outcomes. Thank you.